Welcome to the EAU podcasts. In this episode, UROONCO RCC Associate Editor Dr. Riccardo Bertolo sits down with Mr. Ben Challacombe from Guy's and St. Thomas Hospitals to discuss robotic resection for recurrent renal cell carcinoma.
Hi, this is Riccardo Bertolo, Associate Editor of the European Association of Urology UROONCO platform Kidney Cancer. We are at the EAU Robotic Section Congress in Bordeaux with the pleasure of hosting Dr. Ben Challacombe, Clinical Robotic Surgery Lead and Fellowship Director at Guy's Hospital and King's College London, for a podcast interview. So, sir, one of your tasks at the EAU Robotic Section Congress is to give a talk about the robotic resection of renal cell carcinoma recurrences. How do you plan your treatment? In the case the recurrent is after partial nephrectomy, what must be the characteristic of the recurrence so that you are confident to manage it with a robotic nephron-sparing approach compared to a radical nephrectomy or an ablation?
Well, Riccardo, thank you very much for asking me to speak on this podcast. It's lovely to be here with this live surgery event at ERUS. This particular area is a rather niche area, but a really important area because every meeting has a case. A clinical MDT meeting would have a case similar to this. And I think for me, it's important that these are discussed in a forum, what Americans would call a tumor board, what we would call a multidisciplinary meeting. Because a number of views and a number of experiences, I think, are often useful. Even though we as surgeons may still have our own primary view, you may still pick up some tips from discussing it with the wider group and going through it with a radiologist. So I think if you have a post-ablation recurrence, that makes the tissue around the kidney very difficult. The fat is super toxic, and therefore really a polar heminephrectomy kind of approach would be the best. Trying to do micro dissection around an ablated tumor recurrence is tricky. The literature on this is that probably 2-to-1 people tend to take out the whole kidney rather than try a nephron-sparing approach. Yeah. For previous partial nephrectomy recurrence, then I think that is slightly different. That I've done that many times to go back in, and it can be a tumor that's just next to the previous tumor. That's the easier example. But if it's actually a recurrence of the primary tumor due to positive margin or otherwise, then I think that there is quite a high chance that's an aggressive tumor. You don't want to be doing an enucleation there. You probably don't want to be doing an enuclear resection. You want to be doing a resection, and you don't want to be dealing with a tumor with vascular invasion. So I think that their niche area needs discussion and consideration and a low threshold to do a nephrectomy if it looks aggressive.
Yeah, thank you. It's very nice insights. And is it routine in your institution that patients are counseled for adjuvant pembrolizumab according to the keynote 564 after the surgery for tumors at high risk of recurrence?
Yes, we've been bringing that in the last year. Since that keynote 564 and then the updated 30-month follow-up, it does show a difference in survival. We've been waiting, I suppose, for a drug to do that for many years. There have been, as you know, 4 or 5 RCTs that didn't show any difference. So we would now, for the higher Leibovitch and higher grade, higher risk tumors, we would be offering those adjuvant pembrolizumab. For the intermediates, not so much. I think the toxicity is still significant, but for the higher risk, definitely.
Thanks, sir. And tell us about your experience with the status of the surgical field, the status of the tissues after the patient has eventually been exposed to immunotherapy or, why not, TKIs or radiation, and you have to schedule a redo surgery.
Yeah, I think that's also an evolving area. We saw a few of these with the TKIs, but with the doublet immunotherapy and some of the other immunotherapy regimes, we're quite often asked to go and take out the primary tumor. I would say the TKIs tended to give very kind of watery tissue. For us surgeons, we would say it was a bit like doing a nephroureterectomy, kind of TCC kind of tissue. Whereas the immunotherapy doesn't quite have the same effect. It's a little bit, it's as if it's been kind of heated up and sort of shriveled up a bit. What we found in particular is doing caval tumors with the robot when people who've had immunotherapy, that we've been fooled by thinking the thrombus was still, had regressed back but it hadn't. It's just kind of stuck to the wall of the cava because it almost like takes out all the water from the tissue and makes it a sort of fibrous little tongues of tissue. So it's an evolving area, but I think we as urologists will be asked to do this more and more because these drugs are so good. And of course, if the scan shows the only active area is in the kidney, then and you're the patient, you want the kidney out.
Yeah. And such complex surgeries suggest another topic. You are among the few European robotic surgeons being users of all the CE mark-approved platforms beyond the Da Vinci Xi, namely the Hugo RAS platform, the Versus as a multi-arm system, but also the Da Vinci SP for single port. How can you manage the decision algorithm among all these platforms, different brands, different access philosophies?
Yeah. It's an important point, and I haven't got a precise algorithmic answer for you.
I can imagine.
I would say that the Hugo, we've had a good experience with that. We can do pretty much any prostate, radical prostatectomy with that. Big ones, small ones, ones with transplants, people with tight pelvises. So that's all fine. And the results have been very equivalent for us. The CMR has a role. We're using that more in pediatrics now. That has a role in oral surgery in our unit. So pediatric urology, because it has small arms, that's, I think, probably where we're going to use that mainly. And for the SP, this is an evolving thing. We've only had it for 4 months, but we've been impressed with it. We've been able to do more cases than we thought. And for the kidney, which is my sort of love, really, I mean, the low anterior approach, the retro approach, the patients love that. So if you have a sensible tumor that's small to medium, so Padua's below 10, or a pyeloplasty, I think the SP is an absolutely wonderful piece of equipment.
This is very nice insight. And are the available multi-arm system interchangeable for you? No, I guess no, because you pretty gave us the answer. I'm asking you if you have any peculiarity of each that you love for a specific indication.
Well, my other passion other than doing the surgery is teaching the surgery. And this is a really important aspect, of course, because can you learn as a younger surgeon on multiple platforms at the same time? And I mean, I believe you can. Young people learn quickly. We have a saying in the UK, which is you can't teach an old dog a new trick, but you can teach young people new tricks, and they can learn. On one day a week, they use the Hugo. On another day a week, they use the Da Vinci. And from what I can see, and we haven't scientifically proven this, they are able to progress equally well on both systems. So their mind is open to change. If you're young, you're not used to being done in one certain set way. So I think absolutely. I sit down on one system. It takes me just a minute or two to get really into it. And perhaps just a few seconds of gentle practice before you actually start the operation in the main part. You can do it.
Perfect. Thank you very much, Dr. Challacombe. It was very nice to share these minutes with you, sharing with us your fantastic experience. Thank you very much.
Pleasure. Thank you for asking me. And we're going to see some more wonderful surgery here at ERUS in Bordeaux.
Yes, looking forward to that.
Thank you for listening to this episode of EAU Podcast. To keep up to date with kidney cancer developments, visit our educational platform, UROONCO Kidney Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.